Okay, good evening, friends. Let me welcome you all to this session of echocardiography in 45th comprehensive course. Today, we are going to talk about aortic stenosis. That's the most important thing. As we saw last week, we talked about mitral stenosis and tricuspid stenosis. All these valvular lesions, to a large extent, they are dependent on two important modalities. One is area by planimetry or area by continuity equation, and second is the peak and mean gradients. So what we need to do in this subset of population is we have to look how we can get the best possible peak and mean gradients and how we can get the best possible planimetrized area or area by continuity equations. So that is what importance is. And many of you will feel now, if you have missed the previous lectures, this is going to make a lot of difference for you now to understand these basic pathologies. Let's move on to my first presentation slide. I always say these words, why we need to assess aortic stenosis if somebody has it. How do we do it? What are the pitfalls? Concomitant lesions when they're associated with mitral stenosis, aortic stenosis, mitral regurgitation, aortic regurgitations, and other lesions. And what are the indication for interventions? My topic will limit to need of assessing, how to assess, and what are the possible pitfalls, and concomitant lesion goes always to level 2 echocardiography. Look, this is a slide which is almost 15-year-old, 1.5 decade old. Issue is, as soon as you develop a symptoms, the cumulative mortality goes up dramatically. The survival goes down dramatically. What does it mean by if somebody with aortic stenosis develop effort, angina, syncope, or dyspnea, his cumulative survival from the age of 60 to 65, it reduces to almost practically half. Then second, this is the event-free survival in asymptomatic patients. This is a timer and this is a percentage. And if you don't then treat them properly over a period of time, obviously the mortality graph keeps on growing continuously in these subset of populations. This is not a literature of today. These are literature around for more than 2 decades old literature. Then, whenever we see aortic stenosis, we have to have a gradients. And when we talk of a severe aortic stenosis, the gradient are more than 4 meters per second. That's a peak gradient. And look at the event-free survival. If your gradients are less than 3 versus more than 4. Here is a graph for 3, here is a graph for 4. It means to say, higher the gradient, poor is the survival. In turn to say that if we have to look for aortic stenosis, we have to be very, very careful to assess their gradients, their symptomatology, and we should act before the patient develops symptomatic. Next question comes, their survival based on NHYA class. A few minutes back, I said effort angina, effort dyspnea, effort syncope. This is the part of dyspnea. If somebody becomes NHYA 3 or 4, it means his survival is much lower than the person who has got an NHYA 1 or 2. And I hope everybody understands what is NHYA 1, 2, 3, 4. So question comes in echocardiography, how do we do it? Well, in this questions, we have to look for severity, we have to look at LE functions, then look for aorta, and this is all which is not required at the present moment. I'm just touching the lines, why these things, they always, whenever we talk of these subjects, they belong to level 1, level 2, level 3. So these are level 2 or level 3 topics, which I'm not going to touch a tip of iceberg, but not in detail, certainly in this inaugural class. Well, this is a slide which has been borrowed from American Mayo Clinic, Rochester. And you know how old this slide is? More than 25-year-old slide, and they are very intelligent people. Why they are very intelligent people? Look, they only said one thing: 2 dimensions Doppler. If inadequate, discrepancy, low cardiac output, go to 3 dimensions: transesophageal, Dobutamine, or cardiac cath. And all these 2 dimensions Doppler, they looked at what? Morphology, gradients, cardiac output, and aortic valve area. So we are going to consider morphology, gradients, cardiac output, and aortic valve area. And all of these things can be done in a very simple, quick way. Let's talk of few important things first. What is M mode evaluation? Though it is historical, but let's have a look at these M modes. This is normal with a central closure line. This is bicuspid with eccentric closure line. Then aortic stenosis with fibromuscular ring, like opening is there, then it starts closing. So many kind of variabilities are present, and which were there when there was no 2 dimensions echo. Like put a probe, put a pencil probe, and you get this kind of a Doppler spectrum pattern. So this is what? This is a low cardiac output state. If you have a vegetation, the vegetation used to be seen in diastole, and the valve opens, it's not to be seen. When the valve was calcified, you see multiple lines in the calcified lesions. So this is how presentation of various issues when we talk of M mode tracing, but still it's useful. I'm not saying they are not useful. Important thing is, I like to say this is right coronary cusp, this is non-coronary cusp. All right, same pictorial dimension, pictorial depiction from our own lab. Here is aorta, right coronary cusp, and a non-coronary cusp with a central closure line. So possibly we are dealing with a leaflet which is normal or bicuspid. As the slide shows bicuspid, so you have to concentrate whether this is possibly eccentric or centric. This does not make any difference as on today in our practice. Next question comes, what are the important 2 dimensions pictures? Look, if everybody is stenosed, any valve is stenosed, what will happen to those valves? They will start showing doming, and this is category seen doming over here. And once you look at a doming in this subset of population, what will happen when we have a colors? The colors will show evidence of turbulence at the level of valve. Here is a valve, here is a turbulence. What is turbulence? Mosaic color pattern by color flow mapping. So I'll go back and come back to the same slide again. Now try to look, the turbulence is right at the level of valve leaflet. The doming is at the level of valve leaflet. So that's what immediately gives an answer. Now you can see a doming in this particular patient. And what is doming? This is what the doming is. Like when the leaflets are projecting out, they're not able to open correctly. That's what is known as doming. And we saw the doming in mitral stenosis also. But the crux of this image is we have a doming, and on top of the doming, we have this particular turbulence right at the leaflet. Why I'm emphasizing again and again? Because number of times we may get a patient who has got a supravalvular stenosis or subvalvular stenosis, where if the valves leaflet are isolated, but you see a turbulence later on distally or proximally according to the same issues. So there itself, the image tells you, look, there's something is happening wrong with the valves. Now, zoomed up picture. Now, nobody can say no, that doming is not there. Very critical doming, they are thickened, they are doming, and that's what the presentation of. But I can't tell you that this is bicuspid or tricuspid. Here is an example of a patient who has got a infective endocarditis. Some of the slides are not Just give me a second. Can't look. Anyway, so if you happen to see a vegetation which is not seen in this picture in the moving slide, this will present as a infective endocarditis. And whenever you have infective endocarditis, you have mildly increased flow velocity, but significant mitral regurgitations. Here is dilated aortic root. This is all aortic root is there. And you have torrential aortic regurgitation. And whenever you see this torrential aortic regurgitation, you have to really look forward whether this valve is stenotic or non-stenotic by looking at what the flow velocities. This is example for a bicuspid or tricuspid. And that's how we look at these bicuspid or tricuspid valve. In short axis view, I'll come down to them again and again to look at the three cusps of the aortic valve. If you happen to see a three cusp in the opening form, I'm going to show next slide more clearly. Then we say tricuspid, otherwise we say a bicuspid valve. I said thickened calcified restricted motion. The turbulence at valvular lesion, valvular level would be at valve, supravalvular and subvalvular. Now let's see how the subvalvular region stenotic is. This is the aortic valve. Here is the subaortic membrane. So what will happen if you look at this aortic valve, if you don't look at carefully, you'll find this patient has got an aortic stenosis. But the pattern of aortic stenosis flow would be a dragger shaped. So this is subaortic membrane or subaortic stenosis. So once you have this kind of a pattern, this is an aortic flow velocity or a pattern, but this is a dragger shaped pattern. What do you mean by dragger shape is? In true aortic stenosis, we have got a very short acceleration time and a large deceleration time. In dragger shape or subaortic stenosis, we have a long acceleration time and a shorter deceleration. By life ke andar, if you have gone to this hills area of Darjeeling, the Gorkhas carry a dragger, kukri. And the shape of that kukri is like a dragger. You can see very well this is the shape of a kukri. That's a dragger. And in aortic stenosis, this would be the pattern. But when you have a subaortic stenosis, this would be the pattern. Then comes supravalvular stenosis. What do you mean by supravalvular stenosis? Here is the valves. But instead of subaortic, here is distal to the valve, which is known as supravalvular aortic stenosis. If you put a color flow, valve will not show any turbulence by mosaic pattern by CFM. But the mosaic pattern by CFM would be seen distally, but the flow pattern would be more or less like aortic stenosis. So valvular and supravalvular will show you a normal aortic flow pattern, but the subvalvular stenosis will show you a dragger shape pattern. But how to differentiate? You have to focus on aortic valve to differentiate between supra, sub, and valvular stenosis. Why important is there? If you have a subvalvular stenosis or membrane is present, suppose this is a membrane. I say this is aortic stenosis and I replace my aortic valve. I'm not going to do a justice to a patient. I have nothing to do with this aortic valve. We just have to resect this subaortic membrane. Similarly, if I got a supravalvular stenotic lesion, I have to look at this particular obstruction, what to do with this obstruction. So the treatment planning changes accordingly. And this can be seen very well in by 3 dimensions echo when we do transesophageal echo. We can see them in zoomed view to look at their aortic stenosis. Short axis tells you a cusp morphology, calcification, paravalvular abscess, valve, area by T, coronary ostia, and patent ductus arteriosus. This is tricuspid. 3 leaflets, 1, 2, and 3. This is left coronary cusp. This is right coronary cusp. This is the non-coronary cusp. This is bicuspid. Like this is 1. This is 2. This could be in this direction. This could be in this direction. This could be in this direction. And single unicuspid valve. But if you have to identify these valves, they should be in opened phase, not in closed phase. I'll be coming to down. Clearly, I'll be able to show you in a couple of minutes. Now, next comes, what is stroke volume? When we talk of aortic stenosis, and we have talked about this calculations, we always look, very important phenomena is stroke volume. What is stroke volume? Stroke volume is a blood which is flowing through LVOT, the stroke volume at LVOT. So we look at an LVOT diameter in Plaque's window. We look at an LVOT diameter in Plaque's window with in mid systole or early systole, when the leaflets are wide open and both of them are clearly seen in this particular window. And then we look at a hinge point of aortic valve from one hinge to another hinge, and that's what the diameter is. So we drive a diameter from Plaque's window. Then we go to either 3-chamber view or 5-chamber view. We go across aortic valve, put a sample volume at LVOT. In this 3-chamber or 5-chamber, we keep a sample volume over here just before aortic valve leaflet, and we get Doppler flow pattern across LVOT. And the very simple formula of a stroke volume is pi r square into LVOT VTI. What is pi? Pi is 3.14. R is radius. We calculated diameter divided by 2 will become radius. Square root of it will give you area. Area into LVOT VTI from 5 or 3-chamber view will give you a stroke volume. And this is the most authentic way of calculating stroke volume in patients. And we can calculate stroke volume from other ways also. Like if we do an ejection fraction, how do we do ejection fraction? We look at end diastolic volume, we look at end systolic volume divided by end diastolic volume, that is ejection fraction. But end diastolic minus end systolic volume is what? The stroke volume. And this stroke volume and that stroke volume should match with each other, provided there is no associated lesion in these patients. Next comes ejection fractions. Well, I always say these words: male more than 52, females more than 54. That's the normal biplane ejection method. But recently in 2021, one paper was published from World Alliance of Society of Echocardiographies. What exactly did it is American Society of Echo. They went to a number of places around the world to make a World Alliance of Society of Echoes. And they said, no, 52 is too less for the males and 54 is too less for the females. They said 57 or 58 is the ideal normal ejection fraction world over. So possibly it's not there in the guidelines as yet, but many people, they started accepting the fact. And we too are, at least I'm the one person like who feels that 56 or 57 or 58% is the ideal ejection fraction, because I always felt like 52 is too less for any of those normal population. Coming back to the same Doppler slides, what this Doppler slides needs to be. This slides need morphology, this slides need gradient, this slide need cardiac output. So we already touched one part. What is that? How do we get a cardiac output? How do we get a cardiac output means, if we have a stroke volume, which we talked about a few minutes back, if we get a stroke volume across this particular LVOT dia, radius, pi r square, LVOT VTI, we get a stroke volume. And if we got a stroke volume, if you multiply by heart rate, you get a cardiac output. Very simple. Now comes aortic valve area. We looked at the morphology. We want to look for a cardiac output, and then we look at aortic valve area. And now this aortic valve area is a little modification of what? Stroke volume at LVOT divided by aortic valve VTI. Many people, they often ask, oh, it's a really cumbersome process. I always say, man, it's not a cumbersome. It's the most comfortable process you can ever find in this earth. Why it's the most comfortable? I've already got the LVOT diameter. I need to look at aortic valve area. So I've got LVOT area now also by pi r square. I need to look aortic valve area. So whatever the blood which is flowing across LVOT has to flow through aortic valve. So once I'm going to 3-chamber view, once I keep my sample volume at LVOT, by pulse wave, I'm getting LVOT VTI. Now I switch over from pulse wave to continuous wave Doppler. What the continuous wave will do? It will measure all velocity across this line, including aortic valve. And once it measures all velocity across aortic valve, what we'll get? We'll get a Doppler flow pattern by continuous wave in this particular fashion. And if you trace them together, what will give you? It'll give you aortic valve VTI. And if I move to next slide, aortic valve area's continuity equation is 3.14 into LVOT diameter divided by 2 into square. And if you divide this by aortic valve area, there's a little lacuna in this. This is pi r square into LVOT VTI divided by, I can do it right now. So this is correct. So if I say this LVOT diameter, LVOT area into LVOT VTI, that will be stroke volume flow across LVOT. And if I divide this by aortic valve VTI, what I'll be getting? Aortic valve area by quantity equation. Very simple, no rocket science. None of these issues are very difficult. Any area less than 1 centimeter square by this calculation is considered as severe. And once we look at this by putting this area divided by body surface area, it becomes what? Index aortic valve area, which is less than 0.6 centimeter square, is considered as severe aortic stenosis. Very comfortable. Now I'll go back to my previous slide. When I'm tracing this continuous valve Doppler across the aortic valve, what I'm going to get is peak velocity, mean velocity, peak gradient, mean gradient. If this peak velocity is more than 4 meters per second, then it's severe. If the mean gradient is more than 40 millimeters of mercury, then it's severe. So now if I go back to my previous slide, talking of morphology, gradients, cardiac output, and aortic valve area, I have looked at all these things together in one go. Morphology, bicuspid, tricuspid, thickened, non-thickened, and any associated vegetation, something like that, or calcification, thickening, all these things can be seen by 2 dimensions echocardiography. Gradients, what we need a gradient is peak velocity, peak gradient, mean velocity, mean gradient. And this, how we get it? We get it by continuity, by continuous wave Doppler across 3-chamber or 5-chamber to begin with. And next thing is cardiac output. Cardiac output is stroke volume across LVOT. This stroke volume across LVOT, if you divide by aortic valve VTI, you'll get aortic valve area as I showed you in this particular slide. And if it's less than 1 centimeter square, we consider as a severe aortic stenosis. I think I'm able to prove my point very comfortably. LVOT VTI, aortic valve VTI, and what else need over here is LVOT diameter. That's what we possibly need. Another thing is LVOT diameter. And you have to be very careful when valve is open and early or mid system. And if you have these 3 parameters, automatically get a aortic valve area by continuity equation. Then aortic valve area less than 1 centimeter square and indexed aortic valve area 0.6 centimeter per meter body surface area. And that's how we say that this patient has got a severe aortic stenosis. If you remember this much, a lot of our work is done already when we're doing echocardiography. Sometimes it becomes very difficult to calculate aortic valve LVOT diameter. Believe my words, even after 35 years of practice, the most difficult task for me to do is LVOT area. This measurement is the most difficult measurement because I have to really make my aorta horizontal. I have to keep my valve open. The valve opening should be as much this, both of them should be open equally. Then I have to look at the hinge point. Hinge point means where valve is attached to. And I do it at least 10 times when I'm doing aortic valve stenosis, severe hepatitis, to look at an exact LVOT diameter. In fact, this is what LVOT diameter is, nothing but annulus. If I'm giving you an annulus area, my surgeon understands my annulus, it has to be about 2 centimeters square. And they take it for granted if my LVOT diameter is so, my annulus would be almost the same. I'm not saying that it will be variable. When this thing becomes difficult, what do? We talk of dimensionless index. And this dimensionless index is very useful. It's nothing, we get rid of LVOT dia. We divide LVOT VTI with aortic valve VTI to get dimensionless index. If it's less than 0.25, oh, it's severe aortic stenosis. Is that right? Perfect. But things are not simple, so simple as they appears to be. Why? Because aortic valve is a tri-leaflet, and whenever it gets stenosed, the jet can go in any direction. And I often give this example. When you are trying to open a tap or change a tap with the water running, and suppose your tap is leaking, and you try to open up the tap without stopping a water supply in that particular pipe, what exactly happens? If you open this tap, the lot of water will flow. But once you try to put that tap, another tap on that pipe, the water flow can go in any direction based on the pressure of attaching that particular tap when you're trying to rotate it to fix it up. The same happens with aortic valve. This is a tri-leaflet valve. The direction of jet could be in any direction. And to look at this particular direction of jet, what we say, we look at 6 windows. And what are those 6 windows where we try to get the maximum gradient is? We said 3 and 5, nothing wrong about it. Then we look at a right parasternal window, suprasternal window, subcostal window. I'm sure like all of you understand where 3 chamber is, where 5 chamber is, where is suprasternal window, what is subcostal window, and finally the right parasternal window. And when I was showing the live demonstration, I showed you all these windows along with right anterior oblique view. And this right anterior oblique view was nothing. Fortunately or unfortunately, when we were doing echocardiography in our lab, this is not there in the literature or books. We devised this particular view in the sense, I was removing a pillow from a suprasternal window from a patient's. And you know what happened? The patient was a little finicky. He said, no, I'm not going to remove the whole pillow. I'm going to keep it behind my right shoulder. My right shoulder aches. So what does it do? Like this, he becomes like this. The right shoulder was little elevated as compared to the left shoulder. And when this was little elevated, what exactly happens? My aorta is over here. So my aorta became really, really prominent. And go back and do it. Put a pillow behind the right shoulder of a patient of aortic stenosis. You will be able to see a very good ascending aorta. And aligned it to a Doppler flow. And that's what we gave the name of right anterior oblique flow. And this is what we do majority of in the lab. And out of the 6 views, anyone where we get the maximum gradient, we consider that maximum gradient as the aortic stenosis gradient. And we mention in our report, look, this is the maximum gradient of aortic stenosis in our reports. So that the next person who is there, who evaluate the same patient again, he understands this is the window where he did it, the maximum evaluations. So I showed you this slide, 3-chamber view, continuous wave Doppler. What we get is peak velocity, peak gradient, mean gradient, and velocity time integral to get you maximum velocities in any particular subject of aortic valve stenosis. This is Suprasternal window, look at the gradient. We get the maximum gradient in this particular window is over here. And if I look at this is 4.54 meters per second. Look at the gradient over here. And the same patient when we were doing in the 3-chamber window, it was only 2.95 meters per second. So we could pass him as non-severe if we do not do in other windows as shown over here. And this is possibly a right anterior oblique view where we could see a large ascending aorta and we can see a real turbulence in this ascending aorta. And this is really catching, the part of this color flow mapping is whenever there's a turbulence, it will show a mosaic pattern. Nobody can miss those mosaic pattern of evaluations. So we talk of 6 windows. Here is this index marker where we look at ascending aorta. So we look at an apical window, we look at right parasternal window, suprasternal window, all these 6 windows. Many of the people, they often ask me this question, sir, why we consider mean gradient and peak velocity? Why not peak gradient as a reason for severe aortic stenosis? Well, look, whatever we do in our day-to-day practice, that's going to be get confirmed. Suppose I'm doing aortic stenosis, I say severe aortic stenosis. Today we accept the values, but previously what the people used to do, hey, there's no way of having a severe aortic stenosis. Let's do a catheterization. And this catheterization, when they did a catheterization, they were able to match this gradients of mean gradients difference much correlated with our echo gradients, and that's why putting a value of mean gradient as 40 and European says as 50 as severe aortic stenosis. So this gradients of mean to mean, LV and aorta, that gives you a very good clinical correlation with our aortic stenosis. Now, what are the pitfalls? There are several of them are pitfalls. Before I'm going to them, I like to spend time again on this pictorial diagram, again borrowed from Mayo Clinic, Rochester. This is a patient in a Prax window. Here is aortic valve, here is aorta, here is alveoli. So it says whatever the blood which is flowing across alveoli has to flow across aortic valve. In thickened aortic valve, we cannot get a perimeterized area in 2 dimensions echo because of not good imaging qualities. In 2 dimension transfluorescent. So what we utilize a content equation. So we get pi r square to get an area into alveoli VTI. The same amount of blood, this becomes stroke volume, the same amount of blood will flow across aortic valve. So we have got an aortic valve VTI. So area at alveoli multiplied by VTI of alveoli is equal to area aortic valve multiplied by aortic valve VTI. If I bring this denominator over here, so what will happen? Aortic valve would be over here, and all this picture divided by aortic valve VTI will give you aortic valve area. And this is what is the most important corrects for aortic stenosis. I'm not going to dwell time on this because quite an old slide, but only I'll say normal area is more than 2 to 2.5. And if it start reducing, that's how we used to say mild, moderate, severe. Today, we are not talking of really mild, moderate, severe. We say severe or progressive aortic stenosis. That's what has changed in 2018, and that was before 2018. If I have to summarize it again, I'll have to go back a little bit again. Why I'm spending time is aortic valve area less than 1 centimeter, index less than 1.6, peak velocity more than 4, mean gradient more than 40, dimensionless index less than 0.25, stroke volume more than 35 cc per meter square area. This has come into picture recently in last couple of years. Why I'm going to talk a little bit later on this particular area. So summary of evaluation is aortic valve area is alveoli diameter into alveoli VTI divided by aortic valve VTI. Alveoli diameter we get in Plaque's window. LVOT VTI, we get an apical 3 or 5 chamber view. Aortic valve VTI, either the 6th window, and then we calculate aortic valve area by quantitative equations. Peak velocity in either the 6th window, mean gradient, either the 6th window. Then we have to the ejection fraction also, apart from this aortic valve area calculation by LVOT. Why the picture of ejection fraction? Because what happens finally? Suppose your ejection fraction is less. So what will happen to gradients? They will be also less. When the driving force is not there, so how the blood will flow across LVOT and aortic valve? So this picture of ejection fraction comes into play. So looking at this ejection fraction, we classify them as at your level. I'm not saying other levels. Sometimes we have a patient of a true or pseudo aortic stenosis where ejection fraction is low, like 40%, 30%, and the gradients are poor. How to deal with that kind of a subject? Before I show that slide, I'll diversify into some other division. But in those cases, when our ejection fraction is low, we subject them for Dobutamine echo, low dose Dobutamine echo. And what this low dose Dobutamine echo is, we give them Dobutamine at a dose of 5 microgram per kg body weight, then 10 microgram per kg body weight. That's it. Heart rate should not increase. And all of you understand the Dobutamine role is beta cell stimulant. We want to give them a beta cell stimulant before giving any tachycardia. So when we give them a low dose Dobutamine, the force of cardiac contraction increases. And based on that force of cardiac contraction, what exactly happens? If our area goes up, the gradient goes up and the area goes down, then we are dealing with true aortic stenosis. If the area also goes up and the gradient also goes up, it means we are dealing with pseudo aortic stenosis. I'm going to come that slide in a couple of minutes. So what are the pitfalls? Pitfalls are existing AR. AR will increase my gradients. Subaortic membrane, very careful. Sometimes we inadvertently measure mitral regurgitation jet by continuous wave Doppler. Then high output state, we should be careful. Then post PVC assessment, if you have an ectopic activity is going on, please do not measure the sample volume after ectopic activity because that will be more forceful. Then in atrial fibrillation, this things becomes really more difficult because sometimes the peak would be more, sometimes peak would be less. So that is where the things becomes difficult when we talk of these kind of a thing in day-to-day practice. So what are the underestimations? How do we really underestimate those subjects population? When we are not aligned with the jets, most important thing is my alignment of jet is not adequate. My jet is eccentric. I have not utilized all 6 windows. And this is aortic stenosis. Proper evaluation is not a job of a novice. If I am doing aortic stenosis, believe even today, I'll say take about 45 minutes to complete my aortic stenosis patients. So what I do in my busy echo labs, like I always say, man, if I got a severe aortic stenosis, I tell them, look, sit comfortably now. Either I give them a time for next day, give them a small dose of any placebo. Look, your heart rate is high, your BP is high, or whatever you can say. Convince the patient, call them again, block that 1 hour for that patient so that nobody is there at that time to evaluate it. What are experiences? And I've put this slide deliberately into this presentations. I don't feel saying these words. Even I have missed one person who was recurrently coming as breathlessness and having a severe aortic stenosis with poor echo window. And unfortunately, one of the time after 3 or 4 echoes, I could really pinpoint, look, this patient has got a severe aortic stenosis. And it's not that we are also human beings, and it's not that our lab is not busy. And that time onward, I said, if I'm looking at some aortic stenosis, I always put a stent on somebody's chest, why he's over here. And somebody is breathless. If I don't find any finding, I spend time on this. Look, something is wrong. If I'm missing something. And that patient, now we got him operated almost 10 years down the line, if I'm correct. And for last 10 years, he's doing reasonably fine. Otherwise, he used to come off and on with breathlessness. And you know, breathlessness was sudden onset breathlessness. And by the time he reaches to you, he's normal and very well accepted fact. Effort angina, effort dyspnea, effort syncope is a very well known feature for aortic stenosis. So improper hurried evaluation. I'll not say improper evaluation, I'll say improper hurried evaluation. So improper hurried evaluation. And majority of you guys have got your nursing home at your hospitals right on top of, right in the bottom of your residence. When the wife is calling from upstairs and 10 patients are lying in a CCU, 10 outside in a waiting room for consultation, another 6 for echo, I'm sure what you're going to do is. So that what is improper hurried evaluation. Not utilizing all 6 window. Respiratory patients where it's very difficult to find good imaging qualities. And on top of that, the Doppler angle of evaluation, if it's not adequate, we are bound to make a mistake. That's what I was saying. Mild aortic stenosis, severe proximal aortic stenosis, severe stenosis, low output stage. We subject them for Dobutamine echo or transesophageal echo. And this is what I was saying when I started my lecture. I'll try to freeze this image somewhere. Yeah. Oh, it's frozen over here. So this is a inverted triangle. And I'm sure all of you are young. Maybe one of you may be old and sitting in this. This used to be India's family planning sign in 60 to 70, when the government advocated family planning. And this used to be the inverted sign of a family planning. So you look at these 3 leaflets, and this is right coronary cusp, right coronary artery rises from here. This is left coronary cusp, this is left coronary artery rises from here, not here, here. And this is non-coronary cusp, there is no coronary artery rise. And if you do a planimetry in this comes out to be very adequate or very appropriate, measuring with aortic valve area by quantity equation. But transthoracic, it's still not possible. I don't know why. Many papers they say we're still not able to get an adequate aortic valve area by planimetry in transthoracic echo. That's what I was saying. Low cardiac output, low pressure gradients is pseudo or true. Put them on Dobutamine echo. If the gradient goes up and the area goes down or remains same, is severe aortic stenosis. And if both of them goes up, the gradient also goes up, the area also goes up by quantity equation, then we are possibly dealing with pseudo aortic stenosis. Few more words before I close it down. What exactly is happening now over a period of time? We have started utilizing the GLS values or global longitudinal strain in aortic valves evaluations. What this GLS does is GLS gives you a value of subclinical LV dysfunctions. And why this thing came into picture is, we found certain people, they were having a gradient less than 40, peak velocity less than 4 meters per second, but their area by quantity equation was less than 1 centimeter square, and they had a normal ejection fraction. If this would have been reduced ejection fraction, we could have called them as low flow, low gradient, poor LV systolic function. Now it's a low flow, low gradient, severe aortic stenosis with normal ejection fraction. And I can add one more word over here for you is normal flow. What is that normal flow is? Normal flow is stroke volume more than 35 cc per meter square area of a body. And when we saw these kind of a subjects, we were really puzzled, what exactly are we dealing with? And a 2019 Journal of American College of Cardiology devoted a whole additional supplement on aortic stenosis itself at that time. And that's how they said, if you find gradient of less than 40, if you find a peak velocity less than 4, aortic valve area is less than 1 centimeter with a normal ejection fraction of more than 55%, and a normal flow, that is stroke volume more than 35 cc per meter body surface area, then you say these people are possibly, we are dealing with low flow, low gradient, severe aortic stenosis, what we call them as a paradoxical aortic stenosis. And how did we truly find these subset of populations? We went on to do their GLS or two-dimensional strain. Their two-dimensional strain was normal is minus 17. Their two-dimensional strain was significantly low in this subset of population. This is a few images from my own clinic, where we are using a 4-chamber, 2-chamber, and 3-chamber. Look at a very good qualitative contraction of this LV function. But the problem with this qualitative contraction LV function is this patient is carrying a severe aortic stenosis. And if I look at his GLS value, look at the bottom, its average is only 14.8%. And that's what the things came up with low flow, low gradient, severe aortic stenosis with normal LV systolic function with poor GLS, known as paradoxical aortic stenosis. And believe my word, this is one entity which was doing worse than a normal aortic stenosis patients. So I'm touching this value because some of you may find this when your gradients are high, your ejection fraction is normal, but you have a severe aortic stenosis. So possibly at time you're dealing with paradoxical aortic stenosis. Now look at this clip of one patient. All of you will agree that this guy has got a concentric LVH. And if you look carefully, this apical septum is possibly less contracting as subject to other one. And more experienced people will say, what? Possibly LV function is not as dynamic it as used to be. 2-chamber view, and comes 3-chamber view, associated aortic regurgitation. And when we looked at the gradients, it's only 2.26 meters per second. Mean peak gradient is 21 with a mean gradient of 9 millimeters. So is it severe aortic stenosis or not? So what do? So we do Dobutamine echo to improve their work. And as I said, if the area goes up and the gradient goes up, we are dealing with pseudo aortic stenosis. If the area goes down or remains same and the gradient goes up, we are dealing with true aortic stenosis. And if you can't do that, you can look at a calcium scoring of these subset. If it's more than 1200, then possibly we're dealing with severe aortic stenosis. If it's do a planimetry, as I showed you a planimetry in this subset of population, very good way of doing a planimetry is just go a transesophageal echo. And if you look at a transesophageal echo, you can really look at the maximum diameter or the area of the aortic valve area in planimetry. So that's how we can differentiate this subset of population from other population where we have some doubts. Same picture has come back, looking at a planimetry area. And today, like I call them as the gimmicks. I don't utilize ever this 3 dimensions echo. Somebody has put it. So I just showing this particular picture. Again, 3 dimensions esophageal echo. And look how poorly it's opening. You can see the opening of this aortic valve leaflet, how poor it's opening, as if it's trying to open. You know, it's a tired horse. Somebody's telling him to open up, man, open up, man, open up, man. Something like that. Relaxed, well, all thickened and difficult to opening. This is hardly open. I'm not going to talk about concomitant lesions. Only a few things I like to say: severe aortic stenosis with low output state, wall motion abnormalities. Dobutamine echo have already touched. Aortic valve area by transesophageal 0.75 or less. That's a true aortic stenosis. In conclusion, all these aortic valve area, index, peak velocity, mean gradient, dimensionless index, stroke volume, GLS, they are the important values. As far as indications is concerned, any person who's symptomatic with above parameters should be subjected for wall replacement, whether it's tower or sour. But if you have a patient who's asymptomatic, there the problem comes. What we do in our lab is we put them on a guarded treadmill to look at their symptomatology. And if these people, they become symptomatic in 1 minute or 2 minutes of stress test, and the gradient goes up more than 5.5 meters per second. Obviously, those people, they are feigning asymptomatology, but truly they are symptomatic. And in your places, I'm not telling you to put on a treadmill because this is a little dangerous work. You can give them a 6 minutes walk test. Let them walk a particular designated space in your place of work. If you're walking for a 6 minutes, they become dyspneic. Obviously, possibly they are feigning asymptomatology because it's a common human tendency. Whenever you become breathless for climbing 3 flights of stairs, you start looking for lift. Whenever you can't walk, you start looking for a car. That's how you become asymptomatic. So these people also do the same thing. They start looking for additional helps to make them asymptomatic. So when we look at this, we always look at 2 dimensions echo, color Doppler, quantification. I touched 2 dimension stain for this particular reason. And when we are still in doubt, like calcium scoring, we go to CT scan. And cardiac MRI also is very helpful modality because this is the aim of age of multimodality imaging. Even cardiac MRI gives a lot of value for aortic stenosis. Sometimes the associated comorbidities, which you often ignore, what are those? Anemia, obesity, COPD. I told you, like even I'm one of the victims for that COPD. Then exercise in testing and natriuretic peptides are useful, or you can go to for CT scan or other transesophageal modalities for echocardiography. So I'm stopping my presentation over here, and